One of my most deeply imprinted childhood memories came on a day when my mom picked me up from middle school. We rolled to a stop at a red light, and I asked her a question from the passenger seat. When she didn't respond, I looked to see why. She was trembling, and tears were starting to come down her cheeks. She reached her arm over to mine, and she said, "You're going to be okay." I said, "What do you mean?" She said, "You're going to be okay. You don't have cancer." In my innocence, I had just realized that the intense healthcare tour I had been through all led to that moment. Months prior, I found a lump underneath my chin. The lab tests were run. I toured the country and visited specialty hospitals, and surgeons removed a mass underneath my right arm the size of a softball. Until finally my mom got the call. She heard her new favorite word, benign. But in reality, my healthcare tour started much earlier. I had an aggressive skull surgery as a baby to correct the shape of my skull because doctors said I'd be socially unacceptable without it. I was hospitalized as a teen because I had a pneumonia that was non-responsive to antibiotics, and doctors had to physically insert a chest tube between my ribs to drain the fluid from my lungs. And it extends to today, where I stand here, quite literally, because I take a weekly injection to treat arthritis that would otherwise cripple me. And as painful as it is, I compare my mom's experience to the experience of a mother I spoke with in Nepal 7 years ago. There's a mother of a malnourished girl, and we were talking because there had just been this new treatment introduced in her community, a simple pace that allowed her to treat her daughter at home. So I asked, "What did you do before this existed?" After a long pause, the translator responded hesitantly, and she said, "The mother said the only available prescription before this was to wait to let her child die." I was stunned. Never before had I felt such indignation. Not at the mother, of course. Her statement was not a reflection of apathy. It was a reflection of desperation. I'm deeply troubled by this because I believe the way we design our healthcare systems speaks about our identities as a society. And the choices we've made to date put the values we all share at risk. No one would ever willingly place a mother in a position where she didn't have a treatment for her child. And no one would ever wish for a hardworking family to go bankrupt due to the cost of their medical bills in the world's wealthiest country. Yet these are the two healthcare worlds I move between. Here, a system of excess. There, a system of access. And confronting that reality created the driving question of my career. Can we design healthcare systems that meet our moral aspirations? I'm here because we can. And it's very easy to say this is all just about money and to dismiss it that way. That if people in Nepal and places like Nepal were just wealthier, their healthcare problems would go away. But you don't need to look beyond the failures of the US healthcare system to see that that's not true. It's undeniable that we get low value for a tremendously high cost. Why? It's a design issue. We have a more is better mindset, and it's exaggerated by a fee-for-service payment structure that creates the wrong incentives. This more is better mindset rewards clinicians for giving excess care that satisfies patients' desires, instead of solving for patients' needs, even if it demands fewer medical interventions. And this is extremely costly. In 2011, we spent $226 billion on unneeded prescriptions and procedures. Even worse is that the way we pay for healthcare in this country has become a form of trauma itself. The leading source of personal bankruptcy is paying for medical bills, and it's responsible for an astonishing 57% of personal bankruptcies. So you can't really argue that this is just about money. Yet what I find strange is that people believe that exporting this system of excess to places that are struggling with access provides an answer. We see countries all over the world combining a more is better mindset with the irresistible incentives of a fee-for-service model, and all they're getting is a pretty poor nickel and dime approach to healthcare that leads their most disenfranchised in a terrible place. Every year, we have 100 million people that are driven into extreme poverty by paying for healthcare out of pocket. That's worth saying again. Healthcare is the driving force pushing 100 million people into extreme poverty every year. So if the system of excess that we have here isn't going to provide the answer to places that are struggling with access, where do we look? Well, I've had the great privilege working over the last few years with an incredible team, trying to build healthcare systems in the world's most impossible places. Places like this in rural Nepal, located 36 hours by bus, one way from the capital city of Kathmandu, where people make on average under $200 a year and are offered very little in terms of basic services like roads, electricity, and water. And what I've found during this pursuit is that an unlikely idea is holding us back. That idea is the idea of sustainability. Now, I know there's risk in trying to take down sustainability, especially in Colorado. But let me explain. That very few people know that we have gone through two great eras where we attempted to define sustainable healthcare. Yet all it led to was widespread misuse of the idea. In 1978, world leaders convened upon Kazakhstan to sign a declaration that said we would have healthcare for all by the year 2000. But what happened as a result is we didn't commit to building healthcare systems that worked fully for the poor. We chose a path of selective healthcare, essentially a basic minimum package that made it pretty easy to go after the low-hanging fruit. And because this, in theory, was cheaper and easier to execute, it became our definition of sustainability. So we lowered the bar. Then in the early 90s, when we saw we were very much off the mark to hit healthcare for all by 2000, we made another attempt. We pursued an aggressive fee-for-service approach, saying that this would only happen if the poor were put in a position where they would have to pay for each of their services. So what you get when you put together both of these attempts is a definition of sustainability that equates to a minimum package of healthcare and special rules for the poor that we would never allow to be applied to those we love. So where does this leave us? Well, I would argue that sustainability is not a benign term as it relates to healthcare for the poor, that it's actually led to vast failures of imagination, and it's prevented us from building healthcare systems from the way they need to be built. But now we're in a different era. And I'm actually just going to go ahead and say I think we should do away with the word sustainability as it relates to healthcare altogether. I think it's too flimsy. It has a scarred history of being used against the poor, and we can do better. We need to move away from the errors of sustainable healthcare and pursue a new approach, something I call durable healthcare. You see, durability demands more than sustainability. Sustainability is based on satisfying patients who can pay. Durability is based on solving for patients regardless of their position in society. Sustainable healthcare means something different for different people, but durable healthcare is one clear promise. It says we'll build healthcare systems the poor can rely on to escape poverty rather than be one that drives them further into it. Durable healthcare is also a system design that helps us avoid the failures of traditional approaches. After years of working in Nepal, we realize that these traditional models have their failings, that none of them alone fully solve for the poor. The private sector isn't accessed due to cost. The public sector often delivers to fail on quality. And the philanthropic sector, though it can create great pockets of excellence, never achieves the scale needed. Yet each of these sectors also has strengths. The private sector can execute effectively with great management. The public sector provides access to a country's poorest citizens. And the philanthropic sector allows us to take risk and to innovate. So what durable healthcare does is it combines the strengths of these three traditional approaches. And the way it does that is it puts a nonprofit healthcare company inside the government's existing healthcare infrastructure and asks that company to deliver healthcare. And it says that that company can only get rewarded with financing is if it gets the results that really matter. Now, this brings together the strength of the sectors. It allows the government to provide infrastructure and financing. It allows the company to provide the management acumen, and it gives them a financial engine to get the results we all want to see. But because that company is a nonprofit, it means the financial engine can be driven by cost recovery and not profitability. And that changes everything. It means a nonprofit healthcare company can dare to go to markets where the private sector didn't previously see any opportunity. They can go there and they can combine government funding and philanthropy to build those systems we want to see, the ones that work fully for the poor. And because the incentives are very different than our system of excess, we remove ourselves from the trap of more is better and fee-for-service. So delivering durable healthcare is more than just a dream. Governments around the world are looking for better opportunities to serve the poorest in their countries. We've come to terms a bit with our history with sustainability and realize that it's been a bit misguided. And what we need now is to put aside our ideological boxes, to put the poorest patients at the center of our healthcare design, and to get clinicians in front of those patients with the incentives to do the right thing. What will emerge is a durable healthcare that does meet our moral aspirations, that honors the dignity of the poor, and that allows us to say to more patients what my mom said to me: you're going to be okay. Thank you.